Welcome to the most impactful week in the movement to end prostate cancer. We're so glad you're here. This event is about you and connecting with experts, advocates, and communities from across the country. Together, we are Zero Strong. Please join us right now for the virtual Zero Prostate Cancer Summit.
Thanks for tuning in to Zero's 2021 Virtual Summit. I'm Shelby Monier, Vice President of Patient Programs and Education here at Zero. Joining me today is Dr. Nilay Gandhi. Dr. Gandhi is a surgeon and urologist at Potomac Urology in Alexandria, Virginia, and serves as the race director of the Zero Prostate Cancer Run Walk in the capital area. He also serves on Zero's medical advisory board. Thank you so much, Dr. Gandhi, for being here today.
Thank you for having me. I'm very excited for this whole summit, and the fact that it's virtual, I think will really be able to impact a lot of people.
Absolutely. This virtual setting is going to allow for so many people to listen to this important topic, especially those who are newly diagnosed and not already in our Zero family. So thank you so much.
I'm truly excited to be able to share with you about prostate cancer diagnosis and testing, kind of the first step towards evaluation into prostate cancer. As the introduction, I'm Dr. Nilay Gandhi. We'll be talking about prostate cancer diagnosis and testing. I did train at Johns Hopkins University, just up the road in Baltimore, a very prestigious site for urologic training, and definitely was exposed to many cutting edge and revolutionary thinkers in the field. And I feel fortunate enough to be able to continue to expand that with my practice at Potomac Urology. So as you've probably heard numerous times, and you likely will hear during the summit, about prostate cancer facts and figures. And as you can see, it's a staggering number. It's exceptionally common, and the numbers continue to rise. You can see the difference in 2019 to 2020 of almost 20,000 additional new men diagnosed with prostate cancer. But what's really striking is the last two areas here. Of a man will be diagnosed with prostate cancer every 2.7 minutes. Just think about that for a moment. And even more shocking, a man will die from the disease every 16 minutes. Think of watching a TV show. Most TV shows are about half an hour. That's 2 men who will die from prostate cancer. That's why we're here today. That's why we want to learn more about this. How can we reduce that number? How can we prevent this from happening? So the statistics all say 1 in 9 men will develop prostate cancer during their lifetime. So again, extremely common, and that's why we're having this very important conversation. The key thing is it can happen to you. Here's a whole bunch of celebrities that have been diagnosed with prostate cancer, and no one is immune to this. And we always think of all these different scenarios. I'll never win the lottery, or that won't happen to me. Prostate cancer is extremely common, 1 in 9 men. And you can see that here are just a few of the celebrities that have been diagnosed and treated for prostate cancer. So when we think of the age and incidence of prostate cancer, this graph really showcases that majority of the prostate cancer we see is between the ages of about 55 to 75. That tends to be where we see the most common amount of prostate cancer, with the average age or the median age about 66 years. When we talk about prostate cancer death, that tends to be extended out about 10 years after diagnosis. So most of the men we see who die from prostate cancer, it tends to be around 75 to 85. So again, diagnosis tends to be a little earlier than the death is about 10 years. But that is where early detection screening, what we're going to talk about in a little bit, will hopefully reduce that death rate. So tools for screening for prostate cancer. As many of you know, there's the digital rectal examination. And I'm not going to go into too much detail there. I don't think there's much that need to be said, except that's the finger in the bottom test. So everyone knows that test. No one likes having it done, but it's extremely important. And I'm going to give one scenario I tell patients who never want to have this test done. When you think of prostate cancer, you could have a normal PSA and still have very aggressive prostate cancer. And the reason for that is that if it's cancerous and it has become very aggressive, it no longer acts like prostate tissue. So it actually does not make PSA. And we actually had a physician friend who referred a patient to us who had a PSA of 1.5, but felt a bump on his prostate. And he ended up having aggressive Gleason 9 prostate cancer, for which he was subsequently treated. But the fact that his doctor did the rectal exam saved this man's life. So even if your PSA is normal, doing a digital rectal examination could potentially save your life. So I know this will sound weird for me to say, but I encourage each and every single one of you to ask your doctor for that exam. It's something that's very simple. It takes less than 5 seconds of discomfort that could save your life. All right. So the digital rectal exam is still a very important part for prostate cancer evaluation. We also have PSA. We're going to talk a lot about PSA during this talk today, about what it is, what it means, and there's been a whole big controversy over the last few years regarding how helpful is it. I'll also spend some time talking about prostate MRI. This is something that has been around, but I think is becoming more and more popular, especially as the guidelines have shifted regarding the use of prostate MRI. So we'll talk about that in a moment. And then there's a few other tests, the Prostate Health Index, PCA3, 4K score. These are additional tests that are now used with PSA and these other markers. And I believe you'll be getting more talks regarding these upcoming at the summit. So what is PSA? Let's start with that. Everyone always asks, what does that mean? And it actually stands for prostate specific antigen. And that's very important because it does not say prostate cancer specific antigen. So PSA is a protein that is made by every male's prostate, whether it's normal cells or abnormal cells, which are concerning for cancer, you still will make PSA. But this is not specific only to cancer, which is why there's been a concern that using this as a screening tool. There's different reasons your PSA can go up. It can go up as you get older, your prostate gets bigger. So as you have more of a prostate, more prostate cells will make PSA. So you can have a natural increase in your PSA due to the size of your prostate. It could go up because of prostate cancer. That's why we use it as a screening tool. It also could go up if you have inflammation in the area, or possibly if you have an infection or a urinary tract infection. That can also cause your PSA levels to go up. It could also go up if you have trauma. If you fell off a bicycle and you hit the perineum, or you got injured playing sports. Even with sexual activity and ejaculation can cause a slight elevation in PSA. So the point is that there's numerous factors that can increase your PSA, but remember, it's called prostate specific antigen, not prostate cancer specific antigen. And that's why it requires a thorough evaluation with your physician to truly assess who's at the highest risk based off of the PSA. Now, race is also a very common risk factor for prostate cancer, and it's more common in African American men than any other race. And men who have African American descent tend to have more aggressive cancers that are oftentimes in locations that are difficult to access from a standard biopsy. And I bring that up when I talk about a prostate MRI. When we look at the incidence of prostate cancer across the board, again, you can clearly see just by looking at this graph that there's a higher rate within African American men. Additionally, we have the same increased death rate in African American men. So this really stresses the importance of screening in an African American population. Unfortunately, a lot of African American men are hesitant to visit with their doctors due to the longstanding history of medical abuses that have occurred. But this is one of the things that I believe the goal of the summit is as well, to really educate the entire population about the importance of prostate cancer screening, because early detection can help to reduce these rates. So to shift gears, I want to bring up what happened in 2012, because it really changed the landscape of prostate cancer screening and diagnosis. And prior to 2012, if you were 50 years old, you would show up to see your primary care doctor. You would always get the finger in the bottom, that's the digital rectal exam, and you would get a PSA blood test. That is once every year that would happen. However, the government was looking at a few different clinical studies, and they came out with a grade D recommendation stating that men should not get the PSA blood test. Now, what happened with that was people interpreted that as they saw fit. People stopped doing the rectal exam because they said it doesn't help. No one would do the PSA test because they said it won't help. And it led to a lot of variability in how people were being screened. The reason this happened is they were citing the harms of PSA. Now, as I told you earlier, this is not a cancer-specific test. However, it is the best tool we have to try and assess someone's risk for prostate cancer. And what was happening were a lot of men were getting diagnosed. That was equaling overdiagnosis. We were finding a lot of prostate cancer that ultimately was not life-threatening. And a lot of these men were getting over-treatment, meaning these non-life-threatening prostate cancers were being treated. And men were ending up with side effects associated with treatment, whether that is erectile dysfunction, urinary incontinence, or pain and discomfort. All these different issues came to the forefront. Now, you may also get false negative or false positive results that, someone could have a high PSA and a normal biopsy, and they're still worried about that number and their risk for cancer. And it can lead to stress and anxiety. So there were a lot of harms that were coming to the forefront as we were discussing this. Now, the next year in 2013, the American Urological Association, which is the governing body for urologists, they, again, were looking at this data, and they were finding flaws in the data that the government used to make that recommendation. And they came up and they recognized that, yes, there was overdiagnosis and overtreatment occurring, but ultimately, PSA is still the best test we have at saving men's lives. And so they actually recommended that you should be screened every 1 to 2 years with both a PSA blood test and a digital rectal exam. And so their guidelines came out saying that men between the ages of 55 to 69 years of age should undergo this screening. This is a table that really just shows all the different organizations that came out with new guidelines. You can see the AUA on the left, ASCO, USPSTF, that's the government force, the ACP and the ACS, the cancer societies, all came out with their recommendations in response to the task force saying, do not do the test. At the end of the day, they all agreed on this key point listed at the bottom, which is called shared decision making. And what that means is have a conversation with your physician. Everyone is not the same, and everyone has their own individualized risk factors, whether it's race, whether it's family history, whether it's your PSA rise, whether it's your MRI findings, whether it's your rectal exam. All these factors play a role to your individualized risk. And that's the important part of this, to have that conversation with your physician. Is this something that can benefit you? The United States Preventive Services Task Force did then change their recommendation to a grade C. And that, again, comes back to what I just discussed. shared decision making. A grade C says, well, you should at least talk to your doctor about it. So they no longer say, don't ever do it. They now say, talk to your doctor about it. So when we talk about PSA, we talked about the standard PSA, which usually when we discuss it, we want it to range between 0 to 4. Now, that can vary as we do this based off of a person's age. So again, you don't treat someone based off of one number. However, you want to monitor where their number is and whether it changes over time. So another test you might hear about is the free PSA, and this is usually used as a percentage. And this tells you the amount of PSA that is free within the bloodstream and not tied to any other proteins in the blood. Now, when people interpret this test, as you can see on this table, when you have a low percent free PSA, 0 to 10%, you have a higher chance of having prostate cancer, 56%. As your percentage of free PSA increases above 25%, more likely that PSA is related to enlargement of the prostate. The key caveat to this is this has been studied for PSAs between 4 and 10. So it does not have significant utility outside of those settings. And most of the time when I see patients who are worried about their free PSA, it's actually because they have PSAs that are less than 4. So keep that in mind as a caveat with this. Another aspect of PSA we typically look at is PSA velocity. This is the rate of increase of your PSA over certain periods of time. And typically, we want to look for that number to be less than 0.75 in a given year. So if your PSA is going up by more than that amount in a year, then that's cause for concern. That's a red flag and cause for us to investigate further. A prostate MRI is something I really want to spend some time on because this is a very important tool that has become more and more commonplace in prostate cancer screening. It's still not approved by most insurances. However, a lot are following suit due to the changes in guidelines. And this is where you lay in a machine for about 45 minutes to an hour, and it scans your prostate, assessing for any abnormalities. And the radiologist will look at your prostate, and there's many different parameters to this. It's called a multiparametric MRI. So there's many different characteristics, and they come up with this scoring system called the PI-RADS scoring system. And you either get a score if there's an abnormal lesion in your prostate, something concerning, they will give it a score of a 1, 2, 3, 4, or 5. Now, to make this simple, typically, if it's a 1 or a 2, it typically represents inflammation or some scarring, but likely is not clinically significant prostate cancer. If it's a 3, it could be in between. If it's a 4 or 5, those are worrisome for clinically significant prostate cancer. So typically, we recommend a targeted fusion biopsy. I'll show a slide in a moment for patients who have PI-RADS 3, 4, or 5. Just because you have a PI-RADS 1 or 2 does not mean you should not get a biopsy. There's still up to a 30% chance you could have prostate cancer, even with a normal MRI. The technology is not there yet to say that an MRI is a substitute for a biopsy. So you still would need a biopsy, but not a specialized fusion targeted biopsy. These are 2 clinical trials that had been done, and the main point is that they found men who had an MRI with a biopsy, it tended to find more clinically significant prostate cancer. Those are the cancers that need to be treated compared to men who did not have an MRI prior. And the analogy I suggest to people is imagine an orange, and that orange has a bad seed inside of it. and I give you 12 toothpicks and I say, I would like you to hit the seed. You might get it, but not with all of them. You might miss it. We don't know. But now if I gave you the same orange with the same seed, 12 toothpicks, and I gave you a map of the orange with where the seed is, you're going to be able to focus where you place those toothpicks to where that seed is. That's the difference between having that MRI as a roadmap so we can specifically target areas of your prostate that are of concern and maximize our chance of diagnosing you correctly so we can start treatment. So the American Urological Association came out with some addendums to their guidelines, and recently, as of April of 2020, they suggested here that key point number 1 here, that based off these 2 clinical trials, there is level 1 data, which is the best data you can get, that they recommend the use of a multiparametric MRI prior to biopsy for all men. So regardless if you've had a biopsy in the past, you're due for a biopsy, the recommendation is to have an MRI prior for those reasons that I just mentioned. So this, again, is a very important tool in our toolbox that's really going to help us risk stratify and identify those men. Remember, the key to this is we want to prevent overdiagnosis. We want to prevent overtreatment. And this is a specialized tool that can help with that. In patients who've had a biopsy in the past and it came back normal, again, it is still recommended. Key point number 1 says that in men with a negative biopsy and their PSA is still going up, an MRI is the recommended next course by the National Comprehensive Cancer Network, the AUA, as well as the Radiology Society. When we talk about that, again, a prostate biopsy is still the gold standard for prostate cancer diagnosis. We still perform a biopsy. This is where you have an ultrasound in your bottom, and we take small pieces of your prostate and look at it under the microscope. Again, we don't have a better test at actually identifying this. We can assess with all the blood studies, urine samples, with prostate MRIs, but ultimately we need to look at the tissue to truly come up with that diagnosis. When we do a biopsy, I talked about using the MRI to do a fusion prostate biopsy. And this is actually what it looks like as we're doing it. We actually draw out your prostate on an ultrasound at the time of the biopsy and map your prostate MRI onto that ultrasound. As you can see here, we actually have a lesion that's marked right here in green, and then this red circle is the center of that lesion. And we're able to use our biopsy and target this area to make sure that we're getting samples from that abnormal region. And typically we'll take 3 or 4 samples from each of the abnormal regions to maximize your diagnosis. So this is a very important technology that has been around and is becoming more and more popular. And I would encourage any man that is considering a prostate biopsy due to your PSA or your risk factors to talk to your physician about the use of an MRI, because that really can make a difference. We've shifted everything in our practice to where every man getting a prostate biopsy will get an MRI. And if it does show an abnormality, we proceed with a targeted fusion biopsy. Again, the goal is to give you the best chance at a diagnosis so we can come up with your best treatment plan. That's what I've got so far. If anyone has any questions, we'd be glad to, please submit them. And if there's any questions, I definitely would love to answer them for you. So thank you for listening. I wish everyone to stay safe, and thanks for joining.
Thanks so much, Dr. Gandhi. That was such an important topic. I'm so glad you hit on all of those different diagnostic tools that we have in the prostate cancer community. I mean, there are obviously pros and cons to each, but I'm so glad you mentioned the DRE, the importance of that, and not foregoing that, because it can be a little bit uncomfortable. And talking about encouraging patients to talk with their doctors about all of the different tools that we have in our tool belt. So thank you so much.
No, absolutely. I think, patients have to be their best advocate for your own health. And I think having these conversations with your physician is the most important first step. So thank you for having me and for allowing me the opportunity to join for the virtual summit.
Yeah, absolutely. We're so honored that you participated. And so thanks so much for taking the time out of your very hectic schedule.
Thank you. Take care.
Thanks. And for more information, you can go to our website at zerocancer.org. Thank you.
The issues you care about most are right here at the virtual Zero Prostate Cancer Summit. Please check out the other topics, sessions, and virtual get-togethers in your Summit app. Remember, you are not alone. Join the Zero community to gain support and more information on prostate cancer at zerocancer.org.